Hello everyone, good evening. I'm Dr. Sridhar here, and I'm very happy to have here with us Dr. Surjeet Madan. She's basically from Karnataka and she has moved to Punjab now. So she's in Jalandhar, where she's a consultant neonatologist, and she's very passionate about POCUS, and she's involved in training the students in that as well. And she's quite active in educating people. So you can come across her posts in the groups on focus-based teaching points. And we are lucky to have her here because she's covering a very important topic for many of you, which is cranial ultrasound. I know she will cover the basics here, and if you're interested, you're welcome to join her course as well, which she's running along with Dr. Mohit and Dr. Kiran as well. So, welcome, Dr. Surjit. Thank you for
Thank
spending the time as well. So, do you want to say a few words about the course that you're running and how you find time for this and how do you?
Yeah, thank you, sir. Thank for inviting me. And Dr. Sridhar has always been a very like a gentleman and very nice person to know. I've met him for last sometimes, but he's been really nice and sweet to talk. And he's actually, I what I feel that he's so much into academics and teaching. We always keep seeing his videos in several groups and all. So basically, I'm running a 30-bedded NICU at Jalandhar, and we have team of doctors. And being in a private practice, it is actually very difficult to get into academics, but I have like very much interest in point of care ultrasound. So we've already been running eco courses in my hospital and with the Nfecho Academy. So recently we have started with the lung ultrasound course, in which more than 100 neonatologists pediatricians from India and abroad have joined. So we'll be soon starting next batches also, if anybody would be interested in lung ultrasound, which is this is first in India. There's no such course, extensive course launched in India
And
yet.
it's a 3 month course, right?
Yeah, it's a three
I
months
saw you
course.
have very nice faculty and international faculty as well. So I will
National,
share the
international.
link to your, the contact number and email in the
Yeah,
chat, in the
sure.
video info as well. So I think you've been made the host. So please try to share the screen now
Yeah, sure, sure.
and you can get going. If I have any questions, we will take it in the end as well. Thank you.
Am I audible, sir?
Yes, yes, please. It's a screen is
And my
seen. You can,
screen.
yeah, please go ahead.
Yeah, sure. So today let's start with some basics of cranial ultrasound in neonates. Yeah, so as I already told, this is first neonatal lung ultrasound course in India, and we have national, very renowned national faculties and international faculties. So our first batch is going on, and the second batch will be starting soon. If anybody interested in lung or ecos, we have 6 months eco batches also going on. So let's start with why we need to do cranial ultrasound in neonates. It helps us in diagnosis of pathologies, and we can optimize the treatment. We can determine what is the timing of injury, and we can assess the neurological prognosis in our little neonates. And we can make decisions on whether the continuation of treatment in the NICU is can be continued or has to be stopped. Anyways, this is very important for our NICU babies, as it's a non-invasive modality. So just a little bit of revisiting the basic anatomy of a brain. So this is a frontal lobe, an parietal lobe, temporal lobe, and the occipital lobes. This is a cerebellum, and we have the brainstem over here. And this is a lateral fissure, and this is called a Sylvian fissure. So that was a coronal section, and when we take a section, this is what we are seeing we have, and this is an anterior view basically. So we start with the lateral ventricles, which opens up into the foramen of Monro and reaches the third ventricle. And then we go down through the cerebral aqueduct and we get fourth ventricle, and which then continues as the central canal of the spinal cord. Once you know this flow of the CSF and the ventricles in the brain, this will help you in a better way to understand when we go and do our cranial ultrasounds. So in a sagittal view, this is how the ventricles are seen. These are the lateral ventricles, anterior horn, the posterior horns, and the temporal horns. And this is a foramen of Monro. We open up like this, and we reach the third ventricle. And then through the cerebral aqueduct, we reach the fourth ventricle, and then to the spinal cord. So how the basal ganglia, thalamus and all look. In a coronal section, this is a lateral ventricle. Here is the caudate, here is the thalamus and the putamen and globus pallidus. And below this comes a third ventricle. So which are the windows through which we do cranial ultrasound? There are four windows. One is the anterior frontanale, which is a standard one, which we all do, and it is easier to do. The another one is a posterior frontanale. You can do few views through the mastoid foramen and through the temporal windows also. But the standard window, which I'll be telling you today, and most of the neonatologists are doing, is the anterior frontanale. And we have two sections. One is a coronal section and another is a sagittal section. So in the coronal section, we have three planes. I'll show you a video how we keep the probe in the coronal section. And another section is a sagittal where we have five planes. So the probe which we use for cranial ultrasound is a sector probe or a phase array probe, which has a small footprint and the frequency is 5 to 8 megahertz. See, now coming now to the coronal view through the anterior frontanal, we have six planes. Look, this is the first, second, third, fourth, fifth. This is how we are cutting the brain into through six planes. So this is how you keep the probe. This is the sector probe, and you're keeping the probe in the anterior frontanale perpendicular, and this is a probe marker. During the coronal sections, the probe marker is always toward the right side of the head of the baby, and you sweep the probe from anterior to posteriorly. You can just look this again. So how we are sweeping the probe anterior to posteriorly. And this way you are taking six sections in the coronal view. We'll now discuss one by one all the six sections. These red lines, you can see these are the six sections. So how do we keep probe in sagittal section? This is again the sector probe, but look at this point, this probe marker will be facing towards the forehead or the face of the baby or near the towards the nose of the baby. So, and we cut the sections, one in the midline, in the sagittal midline, and two on the right side and two on the left side. This midline section is called as midline sagittal view, and the lateral two ones are called as right and left parasagittal views. This is how you keep the probe in the anterior frontanale and then sweep left and right. You're sweeping, so you're sweeping towards right and then towards the left so that you get the parasagittal views. So now starting with the coronal views. So this is the first coronal view, where the probe, you're cutting the probe at the frontal cortex. This is a frontal cortex you're cutting here. So look here. This way you're cutting. This red line is the first view which I am going to show. This is cutting the frontal cortex and the orbit. So this picture you get on your ultrasound. This is the interhemispheric fissure. This is a white matter on the both sides. These are the frontal lobes. This hyperechogenic line which you are seeing is the cranium. And this is the orbital fossa. The second plane we go sweep little posteriorly. From the anterior, you move towards the posterior side. So you cut through the frontal horn of the lateral ventricle. See, here is the frontal horn of the lateral ventricle. You are cutting the section through the frontal horns. This is a picture you get, and I'll describe you what all we can see. This is a interhemispheric fissure. You can see the lateral ventricles. This is a corpus callosum. And this anechoic area is called as cavum septum pellucidum. This Y kind of fissure is the Sylvian fissure. Here is the frontal lobes, and here you can even see the temporal lobes. Going to the third plane in the coronal view, look this is the third plane where you are cutting through the foramen of Monro. This is also called as mid-ventricular view. This is again the third view in the coronal sections. So this is how the picture you see. Again, this is the interhemispheric fissure. These are the frontal lobes. This is a corpus callosum, and this anechoic area is the cavum septum pellucidum. These lateral black area or the anechoic area are the body of the lateral ventricles. And then just beside this is the caudate nucleus, then is the thalamus. This again, when you go down, these are the third ventricles. Foramen of Monro opens up into the third ventricle, and you have laterally the internal capsule. And when you go below, these are the pons and the medulla. So this is how you in the mid-ventricular, I just highlighted the caudate. These are the lateral ventricles I showed you. These are the caudate nucleus, and this is the thalamus. This is a foramen of Monro. So the next plane, we go little posteriorly, and this is a fourth plane which is posterior to the foramen of Monro. This picture you find, and in this again you can see interhemispheric fissure. This is a corpus callosum. You can see the Sylvian fissure. You can see the cerebellum here. The beauty of this is that here you can see the cerebellum and the cisterna magnum. Then when you go more posteriorly, see this is a lateral ventricle. This is a trigone of the lateral ventricle. So you're cutting through the trigone of the lateral ventricle. And these echogenic, hyper-echogenic white areas which you see are normal. And these are called as choroid plexus. And in between here you have the corpus callosum. This is a trigone view. So next is the occipital cortex view, which you are cutting this section posteriorly. When you go the most posteriorly, you will get the occipital cortex. This red line is showing how you are cutting the occipital cortex. And here you can see the white matter, periventricular white matter, the parietal lobes and the occipital lobes are seen. And this midline line is a echogenic line is a interhemispheric picture. Mainly you get the periventricular white matter in this picture. So now coming to the sagittal views, we have 5 planes as I told you. When you keep the probe just perpendicular to the vertically, you keep on the anterior frontannulae and then you will sweep left and right. Look at this video. So you're sweeping towards the left and then towards the right. If you sweep towards the left, you can see the parasagittal plane 1 and then second one on the left side. When you sweep towards the right side, you will get 2 planes on the right side. These are called as parasagittal views. Right? This is a midline view. When you have kept your probe perpendicular this way, look at this picture, I've kept it just on the anterior frontannulae. Where is the probe marker? It is towards the forehead or towards the nose of the baby. This is the picture we get. This is the corpus callosum. Then comes the cavum septum pellucidum. And this is a cavum vergae. This is the thalamus. Then you open up into the third ventricle. This is the aqueduct of Sylvius. This is the fourth ventricle and this is the cerebellum. This is how you see in the B mode or the 2D gray mode. You can see this. Here is the, I have labeled here, this is a corpus callosum. So cavum septum pellucidum, and you have a lateral ventricles. Then a third ventricle here and the fourth ventricle here. See, ventricles are filled with fluid. So ventricles you can see as anechoic areas. Anechoic means the black areas. The fluid in our scans is always white. is always black. So just an imaginary picture, look at this. This looks like a lady. The beauty of this view is that it looks like a lady in a frock, in a dress kind. So this view is also called as lady in dress view, or this picture is called as lady in dress sign. So once you sweep towards the left or right, you get the body of the lateral ventricle. This is the anterior horn. This is the body of the lateral ventricle. This is a trigon. O stands for the occipital horn, and this is the temporal area. This is how you can visualize. And here is the caudate and is the thalamus, and you have a groove in between, which is called as caudothalamic groove. I'll show you. This is the lateral ventricle. This, and you have a choroid plexus here. The hyperechoic white area in the ventricles, which is moving, is not the bleed. It is a choroid plexus. This is a caudate nucleus, and this is a thalamus. The groove in between is the caudothalamic groove. Look at this picture. This is a choroid plexus. This is how you see the echogenic, hyperechogenic area, and this is the lateral ventricles, anterior horns, body, posterior horns, and the temporal horn. I hope you can see a groove, an echogenic line here. This is a thalamus and this is a caudate. So this is the caudothalamic groove. Next, as you sweep more towards laterally in the parasitus, you can see the cortex. This is how you can see the different lobes in the cortex. And you can see the periventricular, white matter, sylvian fissure, and the temporal lobes. So there are other windows also where you can scan, but the standard one is through the anterior frontannulae. You can even do a ultrasound, cranial ultrasound through the posterior frontannulae, and you can see a similar picture of the body of the lateral ventricle with the choroid plexus. Overall, whichever view you go, you might get a different view, but overall the things will be similar. Another is a temporal window where from the anterior frontannulae, if you take your probe laterally, just above the ears, you will get the temporal window. This will come with the practice. And this is what you see, a similar picture as you had seen in the coronal section, third view, which is a foramen of Monro view. The similar picture, if you want to see the bleed or any pathologies, you can even see in the temporal window. Next is a mastoid window. Just behind the ear, you have a mastoid window. You can place the probe there, and your probe marker will be towards the head. And the importance of this window is that you can see the cerebellar hemispheres. So any cerebellar bleed or any pathology, you can see better in the mastoid view. You can see the vermis, you can see the fourth ventricle, and both sides are the cerebellar hemispheres. So very important thing which is helpful in our NICU practice is to see the arterial Dopplers. The most commonly which we usually do is the anterior cerebral artery. So keep this in a sagittal plane. The probe is towards the head, and in the midline sagittal view, you can see this red flow which is covering over to the corpus callosum, and this is the anterior cerebral artery. First you identify ACA, then you can put a probe. Look here, you can put a Doppler on this. You put a pulse wave Doppler on this and you will get this kind of flow. This is a peak systolic velocity of the ACA. This is a peak diastolic velocity. What do we calculate by this? We calculate the resistive index, which is a peak systolic velocity by the peak diastolic velocity minus divided by the peak systolic velocity. This is the formula. How does it help? See, in this picture, this looks quite a normal kind of ACA flow. But if we see the second picture, here the diastolic flow is absent. Right? It can be absent, it can be reversed. Here in this side, you can even see the reversal of the diastolic flow. The resistive index is 0.6 to 0.85. The importance of doing resistive index calculating is in hydrocephalus, in asphyxias. If it is less than 0.56, we can prognosticate to our attendants that this baby has a poor prognosis. And when you are dealing with a case of hydrocephalus, you want to do some intervention, you want to drain the fluid. So we usually do a Dopplers of ACA, and if it is more than 0.85 or zero point 0.9, then that is an indicator that you need to drain the fluid for the hydrocephalus. So you can also do a resistive index in the MCA, and this is done through the transtemporal window. So this was some basics regarding cranial ultrasound. Next, we can just cover a bit of pathologies. Like the most commonly we come across intraventricular hemorrhages and hydrocephalus in our NICUs. So which babies do we need to screen in our NICUs? As we all know, the germinal matrix hemorrhage is very common, and the incidence is 15 to 20% in infants at less than 32 weeks gestation. It is not uncommon in term babies also, but because it is very common in the preterms, so we need to screen all the babies who are less than 32 weeks gestation or who are less than 1500 grams, irrespective of the clinical signs. The babies who are more than 32 weeks or more than 1500 grams should be screened if they have risk factors like perinatal asphyxia, tension pneumothorax, with some abnormal neurological signs, babies throwing seizures or is lethargic. So, and all the ventilated babies should be screened for IVH. So there are different protocols which we follow to do a neurosonogram in our neonates, in our NICUs. If your baby is less than 28 weeks or less than 1 kg, right? So we do at the 6 hours of age, and then at day 3 to 1 week, and then at the 4 weeks. In case you are seeing some intraventricular hemorrhage, you can do it frequently also. That is the advantage of ultrasounds, that there no radiation exposure to the baby. You obviously cannot go for CT scans repeatedly. So this is a very handy bedside tool which helps us to do multiple serial ultrasounds. So in a baby with 28 to 32 weeks of gestation or 1 kg to 1500 gram, you can do your first cranial ultrasound at day 3 to 1 week, and then at 4 weeks, and at the time of discharge, you can do it. In a babies with 32 to 34 weeks who have risk factors like babies on ventilator or had surfactant need, or there was pneumothorax or acidosis, or there is Apgar score was low. So you can do it day 5 and 1 week, and as you feel it is required, you can keep doing the cranial ultrasounds. So there's a Volpe's classification based on the cranial ultrasound done. As we all know, the first place to bleed is a germinal matrix. We have germinal matrix hemorrhage, and if there is very minimal IVH, that is less than 10% of the ventricle area on a parasagittal view is involved, then it is called as grade 1. If the IVH is between 10 to 50% of the ventricular area, it is called as grade 2. And the grade 3 is when the IVH is in more than 50% of the ventricular area, usually distance to the lateral ventricle at the time of diagnosis. And in case the baby has gone into, like, has periventricular echo densities also, periventricular hemorrhages, or there is parenchymal infarct or venous infarct, then this is called as a more severe form of severe grade of classification. So this is how we can see, look here, this is a lateral ventricle, only less than 10% is bleed, and this is 10 to 15% will be grade 2. Grade 3 is when more than 50% is involved, and grade 4 is almost the whole of the lateral ventricles with the periventricular hemorrhage or periventricular infarcts are also seen. This is a grade 4 and a severe form of IVH. So after IVH, post-hemorrhagically, baby can develop hydrocephalus. So what is hydrocephalus? Or ventricular dilatation. It can occur secondary to some disturbance in the CSF dynamics. So the ideal position of of the probe and head is in the coronal section. You have to check for the dilatation of the ventricles. Ideally, for few of the ventricles, we'll be doing in third section of the coronal view, which is also called as foramen of Monro. And this is how you keep the probe in on the anterior frontal. A probe marker is towards your right side. So this is a lateral ventricle, and there are a few measurements which we are supposed to do. One is the ventricular index, then is the anterior horn width. You do thalamo-occipital distance, and the third ventricle width. I'll just show you how to do. This is the midline, and you start measuring from midline to the lateral border of the ventricle. This is the ventricular index. And the when you take the a diagonal line, when you put in the lateral ventricles in this view, this is called as the anterior horn width. And when you go to the sagittal views, the parasagittal view, this is the thalamo-occipital distance which you measure in the parasagittal view. Either on the left or right side, you can sweep while you have kept your probe on the anterior frontannulae with the probe marker towards the head of the baby, and you sweep left and right, you get a parasagittal view. From here, the thalamus ends. So this is the thalamus to the occipital. Thalamo-occipital distance has to be measured. So you also need to measure the third ventricle when you, after the foramen of Monro view, when you are opening up the third ventricle, this is the distance. This is how you measure the lateral borders of the third ventricle. So there are some action plan has to be taken when the width increases to a certain measurement. Like if the anterior horn width is more than 4 mm or it is more than 1 mm over the 95%, you have percentile charts for all the measurements. And if the thalamo-occipital measurement is more than 26 or more than 1 mm over the 27 percentile, and third ventricle is more than 3 mm, then means there is the action plan has to be taken by drainage or whatever indicated, whatever is indicated. So it is better anterior horn width 4 mm, thalamo-occipital 26, and third ventricle 3. So you can remember just these three upper limits of the width of the measurements. So this you can also measure the fourth ventricle width also. So there can also be post-infective hydrocephalus, and this is an all just thought of showing you how the dilated ventricles looks and how the normal size. See, this is a normal size ventricle, and this is a dilated ventricles. You can do the measurements here as I showed you, and the walls are also thickened if it is post-infective. So this is a normal thalamo-occipital distance, and this is a dilate. You measure from thalamus to the occipital. And this, you remember, it was more than 26. You have to do an action plan. And just a picture to show how the brain abscess looks. This is again a parasagittal view where you can see in an echogenic circular kind of thing. This is a brain abscess. And in it also helps us in detecting PVL. Like you can see there again parasagittal view where you can see multiple cysts. This baby progressed to PVL. So this is how periventricular leukomalacia looks. So cranial ultrasound is also helpful in HIE babies. There is hyperintensity. See, this is the echogenicity has increased even here in the periventricular areas and in the cortex. Again here, and this is how near the thalamus and the periventricular area, in fact, is also there, and there is increased echogenicity. So my take home message is that you should always know the anatomy before you take any action. And the standard window which we follow is the anterior frontannulae. And there are 6 coronal sections, right? We went through, and there are 5 sagittal sections we just learned. And you need to practice again and again. And by doing several cranial ultrasounds, it will be very easy for you to learn, and you can take the pictures of different coronal and sagittal sections when you are scanning and keep in your phone with the labeled ones. So when you keep labeling them again and again, you will come to know and you will recognize what part is what. And this is what I thought in, like, I tried to concise and explain the cranial ultrasound basic views and few pathologies.
Amazing. Can you please stop sharing the screen?
Yeah, sure.
I think it was very fluent and concise as well. You covered everything in a short duration. Uh, you spoke really clearly as well. Thank you so much, Dr. Surjit. And
Thanks.
this is one of the first POCUS applications all of us were familiar with. I trained in my DM from 98 to 2001 in PGH Chandigarh, and we used to do cranial ultrasound right from our first year. And actually, the postgraduate trainees in PGA used to do that as well. We used to print in those days a record and all these sections. It was fascinating, and unfortunately, in those days, we used to have many women coming with poor obstetric history. And as you said, the withdrawal of care was a common issue when we have a grade 4 IVH. But we are moving away gradually from prognosticating too much based on a grade 3 or a grade 4 IVH, because we are seeing more small babies. Extreme premature babies are at higher risk of these problems. At the same time, it doesn't seem to increase the risk as highly as we used to think. I mean, I know the risk is not the same, but we used to be very grave in our prognostication. But I've seen quite a number of grade 3, grade 4 IVH who seem to do reasonably well, and similarly those with the normal scan who seem to do unexpectedly poorly. So there are multiple factors going into. So withdrawal of care should be a question only if you're really sure about the prognostication. I mean, and it's very hard to be clear based on the initial picture in a small baby. One of the comments is about the timing of the ultrasound. Again, there are different protocols, but with IVH prevention bundle coming up, and many units are moving away from the day one scan, if I mean, even in the extreme
Yeah.
premature, because withdrawal of care based on the scan itself isn't that common, and you're not going to act. So if you are clinically worried that there is a drop in hemoglobin or bulging fontanelle, you may probably do it early, but otherwise day 3 or so is reasonable time for the first scan, even in the tiny babies. But overall, it depends on your unit practice as well. And some people are conservative in the number of scans they do, but if you have an abnormality existing already, you should definitely do it. And in terms of the extreme premature babies as well, the follow-up scans, as you said, the post-hemorrhagic hydrocephalus, sometimes we get just a grade 1 bleed in the beginning, but then they end up with the hydrocephalus later on. So the dilatation may happen, and we need to continue monitoring them. And in monochorionic twins, there is a high risk of PVL as well because of their circulatory changes in utero. So that's a high risk group. You may want to target a late scan around day 3, day 4, I mean, week 3 or week 4 to pick up the changes. If they had exposed to in utero asphyxia, you get early PVL as well. So if you see bright echogenicity on the first scan, many times it's normal, but you have to adjust the gain settings and see, but you may have to monitor the scan progressively till it resolves, because some of these may be in utero hypoxic insult as well. In terms of the probe technique, I mean, you mentioned about the positioning, and in terms of contact, it's very important that we train ourselves to have a good contact. So use a good amount of gel, especially if the baby has a lot of hair, it can be difficult. Can move the hair a little bit and keep a good contact, a firm contact with the surface, and move the probe. When you sweep back and forth, you need to have good contact. You have any tips on that?
Yeah, no, definitely. You should have a good gel and contact their hair also on the head sometimes, so that can also obscure. So I think we can clean the head, and then the gel sufficient amount has to be
And
there.
then
And
like,
the most important is do not put much pressure on the head of the baby, because they're already so delicate. And even I have seen that grade 2, grade 3 also babies have settled really well, and the future prognosis also have been really good. Grade 4, not much of, like, not seen.
then the
Yeah, clinically also
hydrocephalus,
they have
yeah, the
deteriorated.
hydrocephalus does prognosticate more poorly because mostly there is white matter injury as well in those babies.
Yeah.
In terms of small fontanelle, what do you do? Any tips on that? If the
In
anterior
the terms
fontanelle
of, I have never faced any
is
difficulty
difficult.
as such. I think we get enough window anyways, as we're using a high frequency and appropriate probe for the neonates. I myself
You,
have never
you mentioned the
faced any
linear probe. I
difficulty.
mean, do you use that when we suspect subdural hematoma or something like that? Or
Yeah, we can definitely use a linear probe also for such things.
used to
But
suggest
I
a
think
glove or
the
keeping a glove as a window. I mean, do you use that if you suspect any
yeah,
supervision?
Yes, yes, definitely
A glove filled
sometimes.
with water as a medium, so to say, increase the distance. But
Yes, definitely. We do that sometimes.
amazing. So
And even myself, I'm like not being doing at 6 hours, or like usually I try to do for the extreme prematures around 24 hours. I do after 24 hours if the baby is stable.
you
So
do the
day one, it is, I
hemodynamic
think, very
assessment.
difficult.
Hemodynamic
Yeah.
assessment at the same time. Of course, if you're doing
Mm.
a lung ultrasound for RDS, you may as well do this at the same time, but in a quick fashion. Yeah.
Yeah, yeah,
So,
definitely.
you have any comments? Anything more to add?
Oh, no, I think everything
I think
is like fine. We
this will
can go
be,
in detail about the pathologies in case
yeah,
is
we can
required.
maybe
We
do a
can have
future
a
session
detailed
as well.
session.
Yeah, I think this will be really helpful to everyone. And I think the time is about to end as well. So, really appreciate Dr. Surjit, and it was great having this session with you. I'm sure it will help a lot of young trainees and doctors to go
Yeah.
through this.
Thank you, sir.
Thank you. Appreciate it.